globe at the bottom of your screen, which allows you to choose the language of your choice. I want to acknowledge Seattle and King County Public Health Department for setting up this town hall in collaboration with Nepal Seattle Society, IAWW, Punjabi Health Board, Pakistan Association of Greater Seattle, Washington Association of Pakistani Physicians, and Worth a Shot. Thank you all for your support. My name is Seema Abbasi. I am a pediatric infectious disease physician and the moderator for this event. I'm delighted to have an excellent panel today, and I'm going to dive right in with my first question. So I'm going to address my first question to Dr. Sonam. So Dr. Sonam, recently we've had a lot of conversation about COVID-19 variants. Can you please tell us what we mean by a variant and how these variants differ from the original virus? And if you can please introduce yourself as well.
Hi, Seema, good to see you. Sonam Nyatsasang. I currently work at Swedish Medical Center as an infectious disease consultant and in travel medicine. Just as a side note, I grew up in India, did my med school there, and worked for a number of years there. So I'm quite familiar with our community in South Asia, and have been involved over the last 1 year supporting COVID work with remote telemedicine with patients in India and Nepal. So, with the variant, as we know, virus by itself, we are talking about the SARS-CoV-2 virus, which causes COVID-19, the disease. By nature, viruses go through mutation, which is a change in the genetic material. And that many times may not affect the character of the virus itself, but sometimes what it does, it affects its character in the form of maybe transmission of the virus, the way it causes disease, the severity of the disease, effectiveness of treatment, right? In the form of treatment, then we also talk about, say, whether how good a vaccine works against it or not. So all different characteristics of the virus can be changed by the mutations of this. And when it causes a significant change, then it becomes a variant of concern. And so currently we are talking about the Delta variant, which was initially discovered in India in around April, which is now the dominant form in Europe and seen now in the United States.
Yeah, thank you so much for that introduction to the variants. And I think a lot of people in the audience are concerned about the Delta virus, especially because this particular virus initially was identified in India. And so my question is, in Washington state, do you know what is the predominant virus right now? And have there been any cases of Delta variant, as far as you know?
Yeah, so actually I have the figures pulled out. Weekly, the Washington Department of State comes out with a statement on the current numbers. And so looking at the figures, the predominant variant right now across the United States and in Washington state is still what is called the Alpha variant, which was originally from UK. And the second one is the P1, which is the South Africa variant. But primarily the Delta variant, what we have is the number right now, they're quoting it at 9.2. But the important thing here is the increase over the week-to-week numbers. In end of April on that report, it did not register a number in that. It was so low. And then just a month ago, actually beginning of the month, it was 4.7. And the anticipation is that this is spreading, the numbers are increasing more than the other variants that we have seen earlier, and that in a few weeks' time, this is going to be the #1 virus circulating in the United States.
Yes, no, thank you so much for that. We know, Dr. Sonam, so we know that, the public health measures like wearing a mask, social and physical distance, and washing hands, they work really well for the original virus as well as the vaccines. They're highly effective against the original virus. So at this point, do we know how well the public health measures and how well the vaccines would work against these new variants, the Alpha variant that we talked about and the Delta variant that we talked about?
Yeah, critically important here. And the one thing that they can all do wherever we are, as you notice, as you noted, the wearing masks, being clean, away from public, those things should not affect what variant it is. Those are things we can do to decrease transmission. Now, regarding the other aspects, the vaccine and the treatments, most of our information currently, clinical evidence comes from United Kingdom, where it has been circulating as the major variant for a number of weeks now. So what they have shown in a series of their reports is that, yes, the vaccines work, and they work really well, not as much as against the Alpha variant, the one that initially came from the UK, but it definitely works. They have suggested that compared to people who are not vaccinated, even a one dose of vaccine is more helpful. But to get a good response, you should get both doses, the full sequence, right? Both doses of the vaccine, definitely helpful. With the Pfizer vaccine, they've shown it's up to 88%. Another critical point here is reducing, even if you do get infected with the virus, the severe disease part is prevented. So like compared to those who are not vaccinated, hospitalization is 75% less in those who have got one dose and 94% less who got two doses. So vaccination does work great. The concern is that, as I mentioned earlier, the way it spreads, it seems that maybe this is quite more transmissible than the Alpha variant. So that is a concern.
Yes, no, thank you so much. And, definitely it is reassuring that in countries like United Kingdom, where the Delta virus is already the predominant virus, it seems like the vaccines are holding up pretty good. So that is another reason to make sure that people do get vaccinated, because it does look that the vaccines that we have available right now do provide good protection. And I will remind the panelists again to please speak a little bit slower, because I think the translators are having a little bit of a problem understanding us. So my next question is to you, Dr. Santiago. Which vaccines are currently available in the US, and could you briefly explain the differences?
Great, thank you so much.
Yeah, if you could also please introduce yourself.
Absolutely. Hello, everyone. Thank you for having me. My name is Santiago Neme. I'm an infectious disease physician at the University of Washington. I'm also the medical director of the UWMC Medical Center Northwest Campus. And I've been involved along with Dr. Manny here, my colleague, in the response of UW Medicine. So it's been quite busy for us for the past 18 months. And I'm very happy to be here with you. I did want to start with a quick addition to the variant question. If you can think of variants as really what the virus really does to adapt to constant changes. And the one nutrient for a variant to really occur is circulation of viruses. So as long as there is circulation of viruses, that is, there is virus replicating or reproducing in an environment, we will have variants. And so far we have 5 what we call variants of concern. And we'll have more, but it's really reassuring what Dr. Seema said, that the vaccines are highly effective. In terms of the vaccines that we currently have in the United States currently, we have a total of 3 vaccines. And basically, I like to divide them into 2 categories. We have the mRNA vaccines, which are made by Pfizer and Mrna these vaccines basically use a genetic code or genetic information that we get when we get the first shot. And then what happens is that information makes the body think that it's actually the actual virus that causes COVID. And then we build immunity to that. And then we need the second dose for a booster for that response. Those vaccines have been found to be highly, highly efficacious, so very, very effective, in the order of greater than 95%. And we also know the vaccines are extremely safe, because right now in the US alone, we've vaccinated more than 180 million people, and we've been closely monitoring the side effects. On the other hand, we have the Johnson & Johnson vaccine, which again, the main goal of the Johnson & Johnson vaccine is to provide genetic information. This way, in this vaccine, they use a virus called adenovirus, and it's more of a traditional type of vaccine, but the goal is the same, and it does the same thing through a slightly different mechanism. In contrast to the mRNA vaccines, the Johnson & Johnson vaccine is a one-dose vaccine. And there are some differences. You might have heard that the Johnson & Johnson vaccine was associated with a higher likelihood, although extremely rare, of having a clot. And that's why the CDC paused it for a few days to really study this. And they found that this is an extremely rare event, more commonly happening in women. So therefore, there is a precaution in terms of whenever a female patient who's young wants to get Johnson & Johnson, I give her that information that although this is extremely unlikely to occur to her, it is something that has been found in the order of 1 case per 1 million. So extremely, extremely rare, but it does happen. And also we're fortunate in the United States to really have a choice. And currently the Johnson & Johnson vaccine, there's just a lot more data on the mRNA vaccines because we've been giving lots of it, but also we started with those vaccines back in mid-December. So there's a lot more research, there's a lot more data, and there's a lot more doses on the mRNA vaccines, that is Pfizer and Moderna. So we know less about Johnson & Johnson, but they're all very safe vaccines. In terms of efficacy, there is a subtle difference between the Johnson & Johnson and the mRNA vaccines, because the Johnson & Johnson has been found to be less effective at preventing mild infections. I want to clarify, no vaccine is perfect. So it is possible to get an infection after being fully vaccinated, but it's extremely rare. And in the mRNA studies, that is Pfizer and Moderna, we've seen that out of 101 million people, we've only found 10,000 infections, and a third of those were without symptoms. So this is how rare it is to get infected after being fully vaccinated. With Johnson & Johnson, we have less. I'm going to try to slow down. I forgot.
You're asking us to pause after every sentence.
Okay.
Thank you.
Thank you. Sorry. I just saw the warning. So I would say in summary, 3 outstanding vaccines. The mRNA had 2 doses, Johnson & Johnson 1 dose. There's a problem that is very rare with Johnson & Johnson around clotting, but all vaccines are highly efficacious. And we do have more data on variants with Pfizer and Moderna because of the breadth of the implementation, because we have so many cases. So there's more research with Pfizer and Moderna currently. Thank you.
Yeah, thank you so much, Dr. Santiago. And I think it's important to put these side effects in perspective, like you said, that with Johnson & Johnson, the US government, put a pause on the vaccine to make sure when some of these cases of clotting popped up, but when they were sure that this the incidence is very low, like you said, a few cases in a million, they felt like that the benefit far exceeded the risk. And that's what the bottom line is. I was wondering if you can say a few words about the cases of, there've been some reports of myocarditis and pericarditis that has been seen in young adults and adolescents after the Pfizer and I think some cases of Moderna vaccination. So have you had any updates on that? Because I know some parents especially are concerned about that.
Yeah, thank you. That's an excellent question. Again, I'm Santiago Neme, infectious disease doctor from the University of Washington. Myocarditis is an inflammation of one of the layers of the heart, and it could be caused by many things, including some viruses. Early on, I would say about a few weeks ago, we started to see a very slight trend of cases after vaccination with one of the mRNA vaccines, Pfizer and Moderna. In looking at all the data, we actually saw that although the Pfizer and Moderna tend to raise your risk very, very slightly across, when you compare the risk, your risk of having this condition in the general population, and when you compare that to the risk of having this condition after the vaccination, the rates are pretty similar, but there was a slight uptick after the vaccination. Now, we've seen that the majority of the cases tend to be mild, and more importantly, tend to be reversible. So folks recover from this. This has been seen mainly in teenagers, young people, and that's true for myocarditis in general. Myocarditis, that inflammation of that middle layer of the heart, is more common in folks who are young. So it's not surprising that this is also more common in that population. So although there is an uptick, we also know that actual COVID infection is associated with a much greater risk of cardiac complications. So in a way, the equation here, the balance, is I have a vaccine that's extremely efficacious, safe, that very rarely, very infrequently can cause this inflammation of the heart. But then I have a virus that has killed 600,000 Americans, right? And given so many more cases of cardiac conditions to our citizens. So you have to kind of weigh that in. So I would say most of us, I'm not a parent, but what I can say in talking to a lot of my colleagues who are parents, the equation is pretty easy for them. This is an extremely rare complication, and very importantly, these have been reversible cases, the vast majority of them. So to me, it's all about risk and benefit. And clearly for me, I continue to encourage and recommend vaccination for all of us.
Okay. Well, thank you, Dr. Santiago. So I'm going to go ahead and ask my next question to Dr. Nandita. Dr. Nandita, there have been many myths, especially on social media, about the connection of infertility with the COVID vaccine. Are these concerns, are there any kind of validity to these concerns? And how do you reassure your patients who might have these concerns?
Great, thank you very much. Again, I'm Dr. Mani. I am an infectious diseases specialist at the University of Washington, and I'm also the Associate Medical Director of Infection Prevention there. So this is a great question regarding this myth of infertility being associated with the mRNA vaccines in particular. I want to assure you that there has been no data to support this claim regarding the potential for any of the vaccines to cause infertility. This notion, this fear, originated from a false claim that was spread, suggesting that the spike protein is similar to a protein on the placenta. And the idea was that if you became vaccinated, that maybe you would cause your body to form an immune response against the placenta and harm a future pregnancy. So that fact that is not a fact, it is a myth that's not true. The vaccines, all of them are processed at the site of injection, and they would not be expected to cause any type of hormonal change that would impact your fertility. But I think that the best data that we have to show that this is not true is that during the clinical trials themselves, the phase 3 clinical trials, a number of women became pregnant. And there were pregnancies that occurred both in women who received the actual vaccine and in women who received the placebo. So we know that there was not an impact on fertility that was different in those two groups. So I think, when I counsel my patients who are interested in having a child and who also are interested in the vaccine, I reassure them that there should be no issue there.
Yeah, no, thank you so much for reminding us that, even with the real world data, millions of doses of the vaccines have been given, and thousands of women who got pregnant since then, even after they got the vaccine, and many of them have delivered healthy babies. So that should be reassuring to a lot of people. My next question to you is, do we have any information as to how long the immunity lasts after getting the vaccines? And then the second part of that question is, do you think we will need a booster dose to boost the immune response?
Great question. I think this topic is on everyone's minds. When the vaccines first came out, it was not clear how long the vaccinations would last and how durable the immunity would be. There is now an increasing body of data to show that the effect is actually quite long lasting, and that there are memory immune cells that likely persist for over a year in the bone marrow. A recent study has shown that. We will need to do more research over time to fully understand how long the immune effect will last. But it's very reassuring thus far to know that the immunity is very durable. Now, I will say that certain individuals who may have immune compromise, or who may have cancer, they may or may not respond to the vaccine as well as others, and their response, their immune response may not last as long. So we're learning more and more about the immune response in those populations as well. But by and large, the vaccine response has been really blown us away with how effective and how long lasting the effect is. Regarding the question of boosters, boosters will almost certainly be necessary, and they are already being produced by the vaccine companies. In particular, the mRNA vaccines, the way that they are produced, it makes it very easy to make a booster vaccine. So they're already well on the way to producing them. I think that boosters will be necessary more so to address the problem of variants than to address the problem of a long-lasting immune response. But either way, it will likely both boost the immune response and make it last even longer, and it will also address variants. So we will more to come on that this fall and winter. We'll have more information.
All right, thank you so much for your response. And, recently FDA approved the Pfizer vaccine for children who are 12 years and older. And many children in our community have actually already gotten the vaccine. Some parents do question that since the disease is not severe in kids, why get the vaccine? Even though COVID-19 disease has been milder in kids, more than 4 million children and more than 300 deaths have happened because of the COVID-19 infection in children in just the US alone. So, and many kids have been hospitalized and had been treated in the intensive care unit. There have been kids who had needed artificial ventilation. So certainly COVID-19 infection in children, even though it is mild, it's not a benign disease. And so for these reasons, as a pediatrician, many of my colleagues and I strongly recommend any child who's 12 years and older to get the vaccine. And studies are underway looking at the effectiveness as well as the safety and the right dose of the vaccines for children who are younger, even 6 months and older. And we're hoping that by fall, the vaccine would be approved for kids who are 5 years and older, and hopefully by next year for kids who are 6 months and older. And I just wanted to see what your thoughts were on the pediatric vaccinations.
Yeah, it is true that the vast majority of children with COVID infection have mild infection, but there are significant complications that have been reported, as you said, in a number of children. And I think the most important thing to me is that by vaccinating children, you're not only protecting them, but you're also protecting their families. You're protecting older individuals and their families, people with cancer and other medical conditions who, as we know, may or may not respond as well to the vaccine. And we're just protecting our community. So, even if the child's actual risk of severe COVID is low, I think that the vaccination has a much greater effect than just on that child.
Yeah, absolutely. Yeah, that's absolutely correct. So moving on, according to the World Health Organization, the pandemic is now on a dual track. While the situation is getting better quickly in the United States and the other European countries, many of the countries back home in Asia and in South America are still very much in the middle of the pandemic. So I want to ask you what your recommendation is for people who want to travel overseas and want to visit family and friends back home.
Great question. So the vaccines, as we've discussed, are very effective and they do protect you, but they are not perfect. And you can still become infected with COVID despite having been vaccinated due to a variant or otherwise. My recommendation would be to avoid travel, if possible, to areas of high transmission until transmission has come down significantly and or until that area has a significantly increased rate of vaccination. And I completely understand the desire to see family and to travel. And I think that every person has to make their own individual decision on the risk that they're willing to take. And certainly we're very fortunate to have so much access to vaccine here. And it's, certainly having been vaccinated, it protects you on some level, but I would still avoid traveling to areas where transmission is very high.
Yeah, no, I agree. And I think what I would add to that is that if travel is necessary, make sure that you're fully vaccinated, which means at least 2 weeks after getting your second dose of Moderna or Pfizer, or 2 weeks after getting your single dose of Johnson & Johnson, so that you have that advantage of full protection, or at least 95% protection that you get from Pfizer and Moderna. So Dr. Santiago, this next question is for you. What is the latest treatment for COVID-19 infection? And I would appreciate it if you can comment on monoclonal antibodies. Do they work? Who would be a good candidate for it? And how can a patient access them?
Yeah, so this is a great question. I wanted to also share with the audience that I'm originally from Argentina. So I'm very close to what's happening in Latin America and the disparities around vaccine access. And I'm personally very worried about that. I also want to say, although I'm not too worried about Seattle, I am very worried about other areas in the country with low vaccination rates. And this is exactly what we're seeing. We are now only seeing patients in the hospital with COVID who are unvaccinated. It's become an unvaccinated problem, right? So we continue to see patients hospitalized with COVID, and they all have that in common: no vaccination, right? Or incomplete vaccination, or only one dose, because I've heard that one dose is effective, right? So I just wanted to touch on that because I think it's a central point, that I think there are pockets. I think in Seattle, we are so fortunate. But in Alabama, where the vaccine rates are so low, they're in trouble. So just to get back to your question, so if you follow the NIH guidelines, you see most COVID, first of all, the spectrum of disease of COVID is quite broad, right? So we have 30% of folks who never have symptoms. Then those who have symptoms, 80% have mild infections. So those with mild infections typically recover. There's a subset of patients who have what we call comorbidities. Those afflictions, those chronic conditions that might put that individual at a higher risk for progression, that is, of worsening. So therefore, if I have a patient who was diagnosed with COVID, but meets certain criteria that make me think that he or she is going to do more poorly than someone healthy, then there is a role for starting the monoclonal therapies. Basically, that is one of the indications. Unfortunately, this is a luxury in the United States as well, because monoclonals are not available elsewhere. So there's one indication of monoclonals in the early diagnosis. They're thought to be most protective when it's within 10 days of diagnosis, but really they're highly, highly effective when it's within the first 3 days of the positive test. But you have to have the right person, meaning you have to have that case of mild disease, recent diagnosis that might progress quickly, and you have to do it early, right? Because what you're trying to do with a monoclonal, you're basically giving that person those antibodies that otherwise they would have had from a vaccine or a prior infection. So you're trying to help them catch up and be more ready to tackle that infection. Let's remember that there's two components to the immune system. We have the antibodies and we have the cellular immunity. That is the memory. And there's a question on the chat about this. Let's not get confused. If we check antibodies on a person and they don't have antibodies for COVID, that doesn't mean they're not protected, because the cellular antibodies wane, they decrease, but the cellular immunity lasts. And this is why reinfections after having COVID are extremely rare. The studies show that it's 0.3%. So I wanted to share that perspective because people are obsessed with antibodies. Let's check the antibodies. That's not the full picture. I would rather have a strong cellular immunity that's going to remember and help me make new antibodies very quickly when I need them, right? It's almost like the difference between having a freezer and the fridge, right? Ready to make ice. Mm-hmm. So in a way, so the monoclonals have that impact. Now there's a recent study that looked at doing monoclonal antibodies in the hospital setting for someone who's acutely ill. And it's a subset of patients who have not built any antibodies, who have not developed any of their own antibodies. So that's the other application or indication, but it's still pretty early. Currently at UW Medicine, one can get monoclonal antibodies if they meet those severity criteria, those indications that are morbidity, meaning people who are overweight, people who have uncontrolled diabetes, people with cancer, people taking chemotherapy, people who have received an organ transplant. So those situations. But in doubt, it's always good to check with your doctor. If you've had a recent diagnosis of COVID, even though you might be feeling well early on, it's good to check because you could be a candidate for this therapy. And it has shown to improve outcomes and prevent that progression. So there's other treatments. I would say you've heard about remdesivir. It's a medication that's been around since the beginning. It's helped cases. It helps like cut the duration of disease in a way. But I would say that the impact of remdesivir has not been astronomical in terms of the differences. There is one drug that we've known for a long time that fortunately is widely available across the world. That's called dexamethasone. It's a steroid, so it's a drug like prednisone, for instance, that it's an anti-inflammatory, and that drug has shown to decrease death and really morbidity in a lot of these patients, and has helped improve our mortality, meaning the likelihood of dying from COVID. So I would say those are the main treatments. There's also convalescent plasma and other therapies that have kind of mixed data. There was a hype initially, then actually in South America, they studied high dose convalescent plasma. Not a miracle drug, I would say. And I would really like to highlight how important it is to have the right care, the right nurse, the right team, to be in the right ICU where people can watch you, people can watch for complications. Dr. Mani specialized, she leads our infection prevention team. There are complications from being in the hospital with COVID, more infections from a catheter, from you get a UTI, for instance, you get a urinary tract infections, you get a central line infection. So there's a lot of complications along the way that someone who has been in the hospital with COVID for a while needs to really tackle because they're more likely. So I would say we're lucky in the US to have had enough oxygen, but mostly have enough amazing healthcare workers who have been there every day, 24/7 for us while people recover.
Yeah, absolutely. Yeah, I agree with you. I'm going to pivot here. I want to chat a little bit about a different but equally important topic. Sadly, there has been an increase in anti-Asian bias and hate crimes in our communities since the start of this pandemic. I want to hear from Lalita about this issue, as she has been at the forefront of this other pandemic. So Lalita, if you can please introduce yourself and share some of your experience during the last few months.
Sure, Dr. Abbasi. Hello, everyone. I'm Lalita Uppala, and I'm the Executive Director for India Association of Western Washington, and I'm also the co-chair for King County Immigrant and Refugee Commission. With regards to the concern on rising crimes, hate crimes against communities which may be targeted because they immigrate from certain parts of the world where variants are coming from, particularly for immigrants from the South Asian and Indian subcontinent. We have concerns about cases of microaggression that we are seeing in our community, and that is concerning. And we learn from spring of 2020 onwards, the twin pandemics of racism and COVID that occurred through the year and have continued in the Asian community. Learning from that, we are proactively trying to get next steps in. We're doing a lot of community education on how to respond when you are observing or being or experiencing a case of microaggression. It need not be a hate crime. It can be somebody bullying you. It can be somebody calling you names. What are your next steps? Who do you reach out to? And how do you address this? Why is it important to reach out to your community-based organizations so that they can help you work through it? If you feel comfortable, then reaching out to law enforcement. And that you don't need to wait for a hate crime to happen to reach out for help. If you feel that you are targeted, and if you feel that your space was invaded and you were at risk or that you were bullied, it is your right to reach out to either your community-based organization, and India Association of Western Washington is one of the several community-based organizations that are working on this effort. You can reach out, or if you feel comfortable, then reaching out to law enforcement on your own. We are working with police departments on different sides of King County to work with them, to work with the South Asian and Asian community, Dr. Abbasi. But most important is to not be a silent bystander. And when you are observing such incidents happening. So this is something for the larger community to understand, that being a silent bystander is being a participant also, and that it is critical. We're also working with the Port Authority of Seattle, asking for more information for international travelers so that they can understand and figure out where the closest testing stations are. We're advocating for pop-up vaccination clinics at SeaTac Airport, that SeaTac be a model for other international airports, where international travelers, whichever part of the world they are coming from, have an opportunity to get educated, to be aware of next steps that they take as they enter the United States, and to be just cognizant of being healthy, being careful, and also knowing who to reach out to at that point.
Yeah, I think that's really important, that many times people in the community don't realize where the resources are. And I think that's really important to know who to reach out to. So thank you so much for that update, and also for all you do for the community. Really appreciate that. I think we're going to play a recorded testimony from some community members next, after which we'll answer some audience questions. In the meantime, please submit your questions in the chat box. You already see some questions, and we'll see if we can get to those after the recorded message.
Hi, I was very hesitant and skeptical about getting the vaccine. Also, being the only earning member for my 2 kids and a single mom, I did not want to lose any time from work, as it meant losing income. But IAWW worked with me and helped me, my friend, and my son, who's 17. I'm so grateful that I'm not on an edge with the fears of being exposed to COVID, as a part of my work is to work at a grocery store. I did have some reactions and side effects from getting the vaccine, but I'm glad I'm vaccinated, so I'm safe around people. Thank you.
Hi, I am Kunjan Kapoor, working as a legal service coordinator and a cultural navigator at IAWW. I myself was quite reluctant initially to take the vaccine when they came out, and still remember the day when my colleague was trying to book a slot for me, and I wasn't sure in my mind whether to go for it and to wait for some time. But 2 things which really convinced me and I got my shot was, number one, my job involves a lot of outreach and meeting people. So I thought, for the safety of myself and for the safety of others, I should get myself vaccinated. And the second thing which came to my mind was, if I am not vaccinated myself, how will I convince others to take the vaccine. So I am very thankful for the work I do at IAWW and to all the frontline professionals for doing an amazing job of getting 70% of our folks vaccinated in the state of Washington. Thank you.
All right, thank you so much. I think those were the testimonials. We did get some questions in the chat box. I see a question about the Johnson & Johnson vaccine, but I feel Dr. Santiago did cover that quite well. There's another question in here. If anyone is traveling from India to Seattle, does that person need to be vaccinated? And in bracket, they wrote Covishield vaccine, or if he has a PCR negative test. So is that enough? Would one of you want to answer that question about, I guess, about the vaccination? And I think one question that comes up a lot, and I think it's related to this, is about the interchangeability of vaccines. So the vaccines, as Dr. Santiago, he covered the vaccines that we are using in the United States, which is Moderna, Pfizer, and Johnson & Johnson, but other countries, they're using different vaccines. So the question that comes up a lot, and I think it's tied to this question too, is that if you get 2 doses or a full course of a vaccine in another country, is that good enough? Or when you come to United States, should you get one of the vaccines here? And I believe what the CDC recommendation right now is that if the vaccine that you got overseas is approved by WHO, so then you're good. You're well protected because WHO has closely looked at those vaccines and deemed them effective. And that include, at this point, the Chinese vaccines, which are the Sinopharm, the Sinovac, and also the AstraZeneca vaccines, in addition to, of course, the Pfizer and the Moderna and the Johnson & Johnson vaccine. But if you received a vaccine overseas, which is not a WHO-approved vaccine, then it is advisable that once you get to the United States, you do get the vaccine, which is available here. And Dr. Santiago, would you like to say a few words about that?
I completely agree with your assessment. It's the same understanding. I'm not aware of requirements of the United States for vaccination before coming to the US. There is a testing requirement. And by the way, that person, if they're infected with COVID, will have a positive test. So it's the same test. So even if you have variants, those tests will be positive. So there's no requirement for vaccination that I'm aware of before you come to the US, because honestly, it's impractical to really ask for that when most countries don't have enough vaccine. In terms of mixing vaccines, to my knowledge, there's only been one study that looked at the combination of AstraZeneca followed by Pfizer or Moderna, so one of the mRNA vaccines. And the results were very positive. There was a very robust increase. And the main mechanism is thought to be that you're basically mixing 2 platforms. So you're using a vaccine that was an adenovirus, kind of more traditional vaccine, with an mRNA vaccine, so a different technology in a way, as opposed to giving the same person the same basically formula twice. So that's the only study that has been widely shared. Now, that's the study world, the research world. In actuality, a lot of folks, I'm originally from Argentina, are coming from Argentina having gotten the Sputnik vaccine, the Russian vaccine. That's not in the WHO. So therefore, those folks are going ahead, and if they get a chance, they get vaccinated. Some people who got 2 doses of AstraZeneca are getting an mRNA vaccine. I don't know why they shouldn't, because based on the research. But the other problem that we have is that unfortunately, well, fortunately for the US, the bulk of the research has been done on the mRNA vaccines. So the other vaccines don't have as much research behind. And mainly, well, it has to do with two things. One is that in the US, we do a lot of research and we have a lot of money to do research. But also, those two vaccines were the first vaccines to really be used. So we've given it to millions of people. So including the first country to have a really successful vaccination campaign, which was Israel, that used primarily Pfizer. So I would say it makes sense that you should be able to mix the studies. We've only seen the AstraZeneca, Pfizer/Moderna study from the UK. I think there's going to be a lot more studies, especially because for some vaccines like Sputnik, the component 2, so the second dose, which is different from dose 1, is not available. So people are like waiting weeks and weeks and weeks for the second dose that's not arriving. So that would be my point. I think we're going to learn a lot more. It makes sense biologically, but it's nice to have the research. Specifically in the US, we kind of do everything by research.
Mm-hmm. Yes, thank you. There's another question here regarding the Delta variant. And so one question is that the Delta variant is causing ear deafness in kids. Does taking vaccine help prevent deafness? And the other question is also on the same lines, that with the Delta variant coming up, are all vaccines currently available in US equally effective? So would one of you?
I think we kind of answer that. There's
Yeah.
more data for the mRNA vaccines
Mm-hmm.
than Johnson & Johnson, just based on the number. I think we're going to have more information on J&J, but people should know that the best, the masking, the social distancing are great tools, but really the vaccine is the solution. It's really the solution to move forward. And even when you look at these variants so far, as Dr. Sonam mentioned, they're effective. The vaccines we have are effective against all the variants. But the biggest really solution to variants is to get vaccinated and really stop the replication of virus in the community. And that's why it is so important. I do want to say one more thing. I also got vaccinated and I had side effects. I was kind of ill for 36 hours, but then it went away. So don't let the side effects that people talk about discourage you from getting vaccinated. Because honestly, getting vaccinated gives you the certainty that you're not going to die from COVID. It's almost 100% prevention for death. So that's something that I tell my patients. It's like we could deal with the side effects for a couple of days, but think about just not having to die from COVID. Thank you.
Yeah, no, you're absolutely right. I think we're very lucky that we were able to get such effective vaccines in such record time. And these vaccines, they look like they work against all the variants of concern. And so that is our best line of defense, and that is a way out of this pandemic. And we're lucky in this country that we're at the point where anybody who wants to get the vaccine can actually walk into a pharmacy and get the vaccine, because there's so many countries in the world where they're still waiting for the vaccines to arrive. So thank you so much. And I don't see any more questions in here. Let's see. And so I would ask the panelists if you all have any final thoughts or message before we end the session.
Is Sonam here? Yeah, there's a question about traveling between India and US, and or whether they should where they should get the vaccination. The standard advice we try to give is try to get vaccinated at the earliest opportunity you get. being vaccinated is always better than not being vaccinated. So don't delay getting vaccinated. And then regarding the hearing loss being reported in some cases with increased frequency, we certainly cannot answer this question with any confidence. We need more information. But regardless, what we do know that vaccines can prevent you from getting disease. So if it is certainly because of the Delta variant, if vaccines prevent you from getting disease, you can obviously, avoid getting those symptoms. But nothing is 100%. So, but vaccines do provide protection, even if it's the Delta variant.
Thank you so much, Dr. Sonam. Dr. Mani or Dr. Santiago, do you all have any other input or any other messages?
Sure. I think the biggest takeaway message that that I had from this is just, wow, these vaccines are incredible, virtually all of them, and we are so lucky to have access to them, and we need to get better access to many other parts of the world. So please get your vaccine as early as you can if you haven't already, and encourage your family members and friends to do so as well, and continue to learn about them and get more information if there are questions that you have.
Thank you.
Yeah, and I wanted to add to what Dr. Mani just said. We give a lot of these forums for vaccine safety education and information. And, I would really encourage that you engage in a conversation with your friends, with your families, those who are not sharing, that they still have doubt, they still have concerns, because right now we've known these vaccines for now 7 months. There's a ton of data, there's a ton of information, and we live in a country where if there's any red flag about a vaccine, we put a pause, we study, and then we reassess. So I feel really lucky to be in this environment, but there's still a lot of people who are not getting vaccinated. So try to engage people in this conversation. You don't have to be a doctor to really share your experience, share what getting vaccinated means to you, and also drive the message that when you get vaccinated, as Dr. Mani said, you don't only do it for yourself. It is true that I feel I'm protected, but I'm also protecting my community. I'm protecting the world. I'm protecting everyone around me, right? That cashier who has cancer and maybe the vaccine is not really taking that robustly for her, right? And I'm protecting her by being vaccinated. So engage in those discussions, and don't think that you know why people are not getting vaccinated. You'll be surprised if you engage in enough of these conversations. That the number one tool here is to listen and try to answer and get the information. Because I think when you give the information, people choose, and they choose to live, and they choose to prevent disease and not have to see any more people really die and get really sick. So that's my advice, and I think we should all engage in this conversation. Thank you.
Yeah, no, thank you so much. That's really good advice. And I would also like to say that if any people in the audience want to get more information about the vaccine or vaccine access, the best website, or one of the best websites to go to is the www.kingcounty.gov/vaccine. There's a ton of information on that website, and there's also information in a number of different languages. So please look at it if you're looking for more information. And I think at this point, we'll go ahead and end. Thank you so much to our panelists for your time and expertise, and also to the King County Health Department for your incredible work with the Asian American communities and other minority communities in our area. The recording for this program hopefully will be available in 3 languages as well as English next week. And thank you to our audience for joining us. Have a good evening and goodbye.